The insight here was that by putting data firmly in control of individuals, that we can actually address a lot of the problems in the healthcare system, a system that is plagued by poor flow of data. So the idea here is that what we're encouraging is something called data liquidity, where the data actually flows to where it's needed at the time. So by putting data in control of the patient, what we're doing is something like what Intuit did by creating the Quicken product. Quicken is a financial management tool that lets an individual accumulate data from across their multiple accounts, investment accounts, bank accounts, retirement accounts, all in one place where they can apply an analytic toolkit to it and help manage their personal finances. It does not actually require cooperation across those banks and investment houses. It actually only requires that the patient have access to the data in a common format from each institution. What you get by having your data all in one place is A, you have an integrated record that you can share with a healthcare provider at your next visit. Many healthcare providers end up delivering healthcare in the complete absence of a historical record. If the patient is from another site, if the records didn't show up, if the patient has arrived in an emergency department at a hospital where they haven't received care before. So this person-controlled health record can be shared with healthcare providers, providing a potentially invaluable source of data to drive clinical decision-making, to reduce errors in healthcare, to reduce duplication of tests and procedures that are needed. B, the patient has now the opportunity, because of the way we've structured the person-controlled health record, to actually connect this data source to something interesting. And these are software applications that do a variety of things that add value to the person-controlled health record, enabling new approaches to disease management, health, and wellness, as well as population health. For example, a diabetes manager might help an individual manage diabetes by integrating data from glucometers, from laboratory systems, from healthcare encounters, and from patient annotations. For example, a social network might connect patients to other patients with similar conditions and in ways that the patient can learn from those patients, be supported by those patients, and actually even glean information about what therapies are successful and what are not in those patients. For example, patients may connect to an application that enables them to participate in a research study, in a clinical trial, or a cohort study, or to contribute their data for scientific knowledge, perhaps getting back information about those scientific results early, before the usual publication cycle. There's a couple of reasons why we put personal control first. And one of them is that by making sure that the copy of the data that you get as you move across the health system is in fact under your own personal control, we believe increases trust in the system so that patients are willing to have their data in this repository. This complete repository has to be entirely trusted by the patient because the patient is so central to maintaining it, allowing the data to coalesce. So that's one very important reason for personal control. The other is that by enabling the data to accumulate on behalf of the patient under their own rights, under their own personal control, we obviate the need for interinstitutional agreements. Competitive health systems never seem to agree to share data for a patient on behalf of that patient. There are too many other considerations. So the personal control model actually changes that dynamic and means that we don't need interinstitutional agreements for data to come together. We only need agreements between the healthcare institution that holds the data and the individual. Since the 1990s, we've been looking at ways to understand what the imprint of a disease outbreak would be across a variety of data sets. And the idea was based on concern over bioterrorism. If there was an anthrax attack and someone sprayed anthrax off the green monster at Fenway Park and exposed 35,000 people, and they all went home and began to experience influenza-like symptoms 3 or 4 days later, how would you know? How would you be able to look societally and say that there are, let's say, 10,000 people out there experiencing influenza-like symptoms? Well, we have evaluated over time many sources of data, including everything from sales of over-the-counter medications to school and work absenteeism to data from click streams, people typing into Google influenza-like illness. We've been able to exploit data from the healthcare system where patients show up at emergency departments, at outpatient care visits with influenza-like illness. Those data have actually been extremely valuable, and what we've learned is that we can discern patterns of disease spread, of outbreak from data that previously had been collected in the healthcare system but not used for this purpose. Because we're using data that are available in a very short time frame, really nearly real time, we can actually put a patient up on our system after they are seen at triage. Data are collected about their location, their symptoms, their age. We can actually have that patient in our system on a map, on a graph, before they're walked back to their exam room.